Good afternoon, Dr. Freer. Would you like to wait until the 2 o'clock start time?
We can go ahead and wait.
Wonderful. All right, we're going to go ahead and get started. Good afternoon, everyone. Thank you so much for joining the Los Angeles County Department of Public Health today, March 17th, for a media briefing. Today, we have the Director of Public Health, Dr. Barbara Pereira presenting, afterwards, Dr. Freer will take your questions. Please remember to use the hand icon, or you may chat me the host to ask a question. Dr. Freer, when you're ready.
Thank you, and good afternoon, and thanks for joining for today's briefing, where I'll be sharing a status update, discussing our post-surge efforts, making note of ways to protect our workers, and responding to your questions. I'll take the first slide. Our county is in a much better place than we were a few months ago when we were at the peak of the winter surge. As we move into spring, community transmission has slowed, which has led to declining hospitalizations and has reduced stress across the healthcare system. Per CDC's risk methodology, LA County remains categorized at a low community risk level. And thankfully, over the past several weeks, we've also seen fewer people dying from COVID, and this is a huge relief. We know that our progress is helped by the protective measures taken by so many of our residents, businesses, schools, healthcare providers, and others before, during, and after our surge. And while this is not forever, we are encouraging a continued focus on sensible safety measures for a little while longer, until we have less virus circulating and community transmission is no longer substantial in LA County. Decreasing spread means that there is a reduced risk for all of us, but particularly for those who are most vulnerable to severe illness and those who have a greater risk for exposure due to their work. I'll start off with the past week's metrics, and as you can see, cases, hospitalizations continue to decline. Today, we're reporting 1,331 new cases. The average number of daily new cases reported over the last 7 days declined to an average of 950 new cases from about 1,100 daily new cases the previous week. If you compare March 10th to March 17th, the daily reported case numbers decreased by 2.2% per day. And if we were to maintain this rate of decline, we would move from substantial transmission to moderate transmission by late March. Our 7-day average daily case rate has declined to 9 new cases per 100,000 residents. And our 7-day average daily test positivity rate has also stayed below 1% for nearly the past 2 weeks. By comparison, on January 2nd, the average daily test positivity rate was 23%. Hospitalizations, a key component of CDC's community level measures, have continued to decline, and we're reporting that 495 people are currently hospitalized with COVID-19. That's compared to 632 just 1 week ago. Finally, as noted, daily reported deaths declined to an average of 34 deaths a day versus an average of 40 deaths a day last week. I do send my heartfelt condolences and hope for peace and comfort to the loved ones of the hundreds of LA County residents who were lost to COVID-19 this past week, and to everyone else who has lost a family member or a friend since the start of the pandemic. Next slide. On Thursdays, we're able to post updated metrics on our CDC community level dashboard indicators. The first indicator is the case rate for the past 7 days. As of yesterday, LA County's case rate is 85 new cases per 100,000 people. As you can see on this slide, this remains below 200 new cases per 100,000 people. The remaining indicators on this dashboard are hospital indicators that serve as a proxy for the level of strain on the healthcare system. The first is the 7-day cumulative rate for new COVID-19 hospital admissions. Today's rate of 4.5 admissions per 100,000 people meets the CDC criteria for the low community risk level. The second hospital indicator is the 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients, which is 3.2% for LA County today. This is also considered to be in the low community risk level. Based on these 3 metrics, our overall community risk level remains low this week, and therefore there are no changes that are needed to our overarching strategies. Next slide. This slide shows our progress since October 1st, 2020, on both of the hospital indicators. The first is daily admissions, shown by the yellow line, and the second is the proportion of beds occupied by COVID patients, shown by the pink line. As you can see, these indicators have tracked fairly closely with each other, and this week, both continued their decline from the winter surge peak, and they're now close to the levels that we saw prior to the surge. As mentioned, both qualify LA County for the CDC's ranking of low community risk. Next slide. The next component of our post-surge response plan is our early alert signal system. We are monitoring a set of 7 early alert signals, 3 community-wide signals and 4 sector-specific signals. These will alert us to possible areas of concern, which may prompt us to realign our strategies in order to slow COVID-19 transmission or contain outbreaks. Of note, our post-surge response plan is a living document that over time will be revised to reflect current conditions. This week, we made several minor changes to the early alert signal indicators. First, because the World Health Organization recommended that BA2, the BA2 subvariant, be considered a variant of concern, we modified our variants of concern indicator to include subvariants of concern. Based on review of additional data, we also increased the thresholds for this indicator to less than 10% for low concern, 10 to 20% for medium concern, and greater than 20% for high concern. Finally, based on a review of the school outbreak data in relation to the total number of school sites in LA County, we also slightly increased the thresholds for school outbreaks so that it's now 7 or fewer classroom outbreaks are cause for low concern, 8 to 14 would be moderate concern, and 15 or more would indicate high concern. As you can see, all of the early alert signals were considered to be of low concern this week. Thus, no further investigation or changes to our prevention strategies are triggered. Next slide. Although the latest sequencing results did not trigger a cause for concern, I'm just going to share updated sequencing results through the week ending February 26th. There are no new variants of concern that were circulating in LA County. Omicron remained our predominant variant, accounting for 100% of all the cases with sequenced specimens collected in the week that ended February 26th. Among the 4 Omicron sublineages that have been identified, the BA.1.1 lineage, a descendant lineage of BA.1, continues to be the primary Omicron subvariant detected in cases in LA County. In LA County, we are seeing a gradual growth of the BA.2 subvariant. That's the red line, the red box that you can see at the top of the bar, along with continued declining COVID-19 cases overall. For our latest measurement period, the week ending February 26, 6.4% of all of our sequenced specimens in LA County were BA.2. For that week, 13% of our positive specimens were sequenced. There's wide geographic variation across the United States in the percentage of sequent variants that are BA2, with the Northeast region seeing a higher percent than what we're seeing out in the West. As many are aware, the BA2 variant is now the dominant variant in many countries, including some in Europe that are facing renewed surges in cases and increases in hospitalizations. It's challenging to tease out the role of BA2 in the increasing case counts in Europe. BA2 arrived in each of these countries at a different time, but the rising case counts are happening at similar times across most of Europe, which might suggest that the circulation of BA2 in these other countries is not the only factor driving increasing case counts. These increasing case counts came shortly after rescinding many public health measures that were designed to limit COVID-19 transmission in many of these countries. And it also is happening at a time that may be influenced by the potential waning of protection from the vaccines. While we know that many in LA County have significant protection from BA2 through vaccination, boosters, and/or recent infection with another Omicron lineage virus, BA1, we are closely tracking the information from Europe, since patterns seen in Britain, in particular, are historically seen in the United States a few weeks later. And even though there's no certainty that we'll experience the surges that are being seen in many European countries right now, given the likelihood that BA2 could easily become the dominant strain, we do have an opportunity to proactively prepare by maintaining our response capacity and increasing vaccination and booster coverage, particularly among those who are most vulnerable. Next slide. We also continue to partner with schools to minimize risks of increased transmission, and we're grateful for the efforts to date that have resulted in high levels of safety. As we transition to lifting masking requirements, we're going to be carefully tracking data at schools over the next few weeks to ensure that transmission remains low. As you can see on this slide, over the last 7-day reporting period that ended March 15th, only 2 outbreaks were opened in school classrooms across the entire county. Next slide. Along with the data regarding outbreaks, our other school indicators also show that there's lower risk for COVID-19 transmission in schools. This slide shows the test positivity rate from periodic and response testing that's conducted at schools through March 11th. As previously noted, the reduction in testing volume is due to the appropriate exclusion of students who recently tested positive for COVID-19 from testing. The test positivity rate continues to decline, and it's currently less than 1%. It's 0.22%, which is lower than it was at the start of the school year, throughout much of the school year, and lower than the community test positivity percent for the entire county. Though not shown on this slide, there have also been significant declines in the number of COVID-19 cases among students and staff in elementary, middle, and high school, as well as among youth sports. And again, this is for the week of March 7th through the 13th, there were about 475 cases reported in students across all of the school settings. This is just slightly more student cases that were reported in elementary schools alone the week before. For the same time frame, cases among staff also declined significantly, with only 52 cases reported among staff across all school sites. And that also is less than half the number that was reported in the prior week. Given the fact that there are over 3,100 TK through grade 12 schools operating in LA County, these case numbers are impressively low. We appreciate that with these much lower transmission rates, there's an opportunity now to reassess the safety precautions that are in place. We do, however, note that all members in a school community can continue to do their part to keep transmission low by staying home when sick, following quarantine and isolation guidance, and wearing masks when indoors at school. For those continuing to wear masks, we recommend upgrading to respirators, including KN95, KF94, and N95 masks that provide higher filtration efficiency. This is especially important in settings where everyone may not be wearing a mask. Next slide. And although we share this relief that COVID-19 is declining in LA County, because we do need to be prepared for the possibility of future surges and for additional variants, new variants that could spread more easily, they could cause more severe illness, or they could evade vaccine protection. We have a preparedness plan and accompanying metrics to guide these efforts. As of today, we also have a new preparedness dashboard, and you're seeing half of it on this slide. And this allows everyone in the county to mark our readiness to respond to changing conditions and challenges. The dashboard consists of 13 indicators that address the 5 key areas of our preparedness plan: outbreak management, testing, surveillance, vaccinations, and therapeutics. The 3 thresholds we assess are if in a particular area we need to improve our capacity or we have adequate or outstanding capacity. When our metrics suggest the need for improvement, we will take measures to enhance our preparedness and be able to track our progress regularly on how we're doing on improving capacity. This dashboard will also be posted today as part of our post-surge response plan website, and as with the 2 other dashboards, the early alert signals and the community risk level, these will all be updated on Thursdays. Today, I'll quickly just review each metric, and in upcoming weeks, I'll focus only on areas where improvement is needed. After we review the dashboard, I'll also talk for a minute about 2 of the preparedness focus areas, testing and outbreak management. The first 4 metrics relate to access to vaccines. We've met the threshold for outstanding for the number of mobile vaccination sites per week and the number of fixed vaccination sites. But as you can see, improvement is needed for the other 2 vaccine metrics. The first is the percentage of eligible homebound referrals who receive their vaccine within 2 weeks from the date of referral. And the second area where improvement is needed is the percentage of residents 12 and older who live in the most vulnerable communities who have had at least 1 additional or booster dose. We've met the threshold for adequate for our outbreak management preparedness metric, which measures the percentage of our high-risk worksite outbreaks that had at least 1 visit from our DPH outbreak team. Under the post-surge level, high-risk worksite outbreaks are defined as those outbreaks that are happening with 5 or more epidemiologically linked cases in manufacturing or warehouse work settings where there are at least 50 employees, at the airline or airport settings, or in any industry that, as I noted, has 5 or more epidemiologically linked cases. There are 2 preparedness measures that are related to access to therapeutics, which are defined for this purpose as oral and injectable medications used to prevent infection or disease progression. The first metric, which is the number of sites in the most vulnerable communities that dispense therapeutics, was rated as needs improvement. The second metric assesses the percentage of eligible residents who contact our public health COVID-19 information call center regarding therapeutics who received the requested and recommended therapeutics. The result for this measure is pending and will be reported as soon as it's available. Next slide. The next set of metrics relate to preparedness in the area of testing. We met the threshold for outstanding for the average wait time for testing across all county-run test sites, and for the percentage of TK through grade 12 schools that have capacity for response testing. Our performance on the metric related to the percentage of skilled nursing facilities that have the capacity for routine response testing is considered adequate. However, it's important to note that with response testing at the skilled nursing facilities, the threshold for outstanding is 100%, and our current rate is 99%. We met the threshold for adequate for the final 3 indicators, which are related to our surveillance preparedness. The first is the percentage of positive case specimens that are sequenced per week. This contributes obviously to our ability to identify variants of interest and concern. The next is the number of service planning areas represented in wastewater collection and testing at least 3 times per week. And this is a measure of our capacity to quickly identify an uptick in the presence of the SARS-CoV-2 virus in wastewater. The final surveillance metric measures the percentage of emergency departments that are reporting data regarding COVID-19-like illness to us. The EDs included will submit these data through our syndromic surveillance system. Next slide. Last week, I just focused a little bit on talking about efforts around vaccine and therapeutic preparedness. This week, I just want to take a minute and talk about testing and outbreak management preparedness, starting first with testing. Ample access to free testing sites, along with access to home test kits, are key to our post-surge response. This can ensure that we quickly identify, treat, and isolate cases and identify close contacts. Having timely test results also enables individuals to know when to avoid close contact with others and when to seek treatment. This map shows 78 LA County and partner testing sites, state testing sites, and sites that are run by other testing providers. At these test sites, all testing is available at no charge to residents, which is why they're listed on this map, regardless of insurance or immigration status. It's important to note that there are many other providers that offer testing to their patients, and that there are also some pop-up testing sites, neither of which we capture on this map. Next slide. While fixed sites offer access to anyone needing testing, part of the preparedness plan calls for ensuring testing capacity in high-risk settings, including schools. This slide shows the percentage of TK through grade 12 public schools that have the capacity to conduct response testing that can help schools identify asymptomatic infections and take steps to prevent further spread of COVID-19. As you can see, between May and July of 2021, as schools were onboarded to provide this testing, the percentage of TK through grade 12 schools with testing capacity increased significantly. And by August, over 93% of schools had this capacity. This allows us to meet the outstanding threshold for preparedness for this preparedness measure. But we do need to make sure that we sustain this testing capacity in schools because it is an important part of keeping our schools safe. Next slide. And just as a reminder, testing does remain an essential strategy during this pandemic, and we never want to experience scarcity in accessing testing again. There are lots of individuals that need to have good access to testing, even now when transmission is lower. At all times, we need to be sure that those who have COVID-19 symptoms or have been in close contact to someone with COVID can get tested as soon as possible, so that if they're infected, they quickly can isolate and, if needed, receive essential medical treatment. In addition, we need to make it very easy for those who are isolating or quarantining to know when they can end their isolation or quarantine. For instance, asymptomatic individuals who are isolated or quarantined may be able to end their isolation period early if they have a negative test from a specimen that's collected on day 5 or later of the isolation or quarantine period. There are many people who also need to test as part of a screening program or outbreak management effort at work or at school, or to enter certain events or facilities. And while screening testing programs may not be as essential when transmission is low, they are essential at high-risk settings, including nursing homes, where routine testing may continue to be needed. Testing is also still recommended or in some cases required for people who are traveling. For instance, if you're not fully vaccinated, you should get a COVID-19 viral test 1 to 3 days before domestic travel, and then get a COVID-19 viral test again 3 to 5 days after you return to California. And we still suggest that testing before and after events and gatherings is sensible, especially if you, someone you're gathering with, or someone you live with is at higher risk for COVID-19 or for severe illness. Importantly, our preparedness efforts need to ensure that we can ramp up our testing capacity whenever that's needed, particularly when transmission is higher. Next slide. There are so many resources that are available for those that need to get tested for COVID-19, and just want to note that for more details, you can visit our COVID-19 testing webpage. We list the criteria for the various testing programs, and we also link to the test sites. The URL is at the bottom right side of this slide, and we also have a detailed list here of testing resources across the county. But I want to note that testing capacity preparedness does involve us making use of all the new ways that people can get tested. So as you can see here in LA County, you can get tested at a test site. You can collect a sample at home and submit it for testing, or you can use a home test kit some of which can be mailed directly to your house. There should be no out-of-pocket costs for COVID-19 testing at the testing sites listed on our webpage. People with insurance can get tested by any provider in or out of their health plan network at no cost. Tests are also free to people who are uninsured. However, some people may need to pay for an at-home test kit or some of the rapid result tests. While most sites should not be charging for these tests, I do recommend that when you go to a new site, please confirm that they're not going to be billing you for any associated charges before you go ahead and get tested. If anyone suspects that a COVID-19 testing site is a scam or a fraud, they can report it at www.bit.ly/DCBA-help. We also have tips for how to spot misinformation, scams, or fraud that's posted on our website, ph.lacounty.gov. The COVID-19 testing webpage, which you can see here, www.ph.lacounty.gov/COVID tests, has all of this information about the types of COVID tests, what test results mean, what you should do if you have a positive test result, and details regarding who should get tested. Next slide. Another one of our essential preparedness activities is maintaining our ability to manage outbreaks, because this is actually an opportunity for us to reduce what we call continued transmission. As you can see on this slide, which shows the 7-day rolling average number of active outbreaks from July of 2021 through March 15th of 2022, there have been thousands of outbreaks at sites across the county during this pandemic. And these outbreaks occurred in a wide variety of settings, all of which skyrocketed during the winter surge, and fortunately, like our other metrics, have recently been steeply declining. While during the surge, outbreaks in the work sites and the places of worship category accounted for the largest number of our outbreaks. Currently, as you can see, the largest number of active outbreaks are happening at our skilled nursing facilities, showed by the yellow line, followed by shelters for people experiencing homelessness, which is the green line. And again, you can go ahead and get this information on our website as well, so that you can see how we're tracking this. For all of our sites that we track outbreaks at, we are seeing, a very significant decline. But that means being prepared to manage outbreaks has to remain a key aspect of our planning. And our preparedness metric that we're using here, the percentage of high-risk worksite outbreaks that have had at least one site visit by our outreach team, lets us know that we're retaining capacity to respond appropriately when there's transmission that's happening at any of our work sites. Next slide. Given that millions of residents spend so much of their day at a work site, protecting the workforce throughout the pandemic and even during post-surge remains a high priority. Doing so helps to minimize staffing shortages, reduces economic hardship, and prevents the spread of COVID-19 in work sites and from the work site to the home. We're grateful to the many employers that have followed public health guidance and implemented measures to protect their workers, customers, and visitors. Although the surge is over, the pandemic is not. And as noted, we still have substantial transmission of COVID-19 across our county. Thus, we do appreciate employers' continued compliance with a series of measures that protect workers and limit spread of COVID-19. I'm going to briefly touch on 4 ongoing responsibilities for employers. First, although masking is no longer required in many settings, employers are required to provide employees with upgraded masks or respirators for their protection. In indoor settings where masking is optional, employers are required to offer for voluntary use well-fitting medical masks and respirators, N95s, KN95s, KF94s, at no cost to their employees who work indoors and have contact with other workers, customers, members of the public, or they're in vehicles with more than one person. Employers that elect to maintain universal masking indoors are to provide well-fitting medical masks to their employees at no cost. Cal OSHA also requires employers to provide respirators upon request for voluntary use to employees who are not fully vaccinated and who are working indoors or in vehicles with more than one person. Employers can also help promote vaccines and boosters among their employees and make it a lot easier for workers to get vaccinated or boosted by offering these at a work site. Ongoing efforts to increase ventilation, reduce crowding indoors, encourage physical distancing, support hand hygiene, and follow cleaning and disinfection guidance are steps that create a safer work environment for the workers, the customers, and the visitors. Next slide. And while many of the prevention measures that I just noted are recommendations, employers are required to take an active role in managing any outbreaks of COVID-19 at work sites. When there is an outbreak at the site, employers are required to make appropriate notifications, including posting a public notice on site to notify the public of possible exposures. They're also required to identify and notify all close contacts of their worksite exposure, as well as exclude cases and contacts from the worksite until they've been released from isolation and quarantine. All public or private employers with 26 or more employees must also follow the requirements of the 2022 COVID-19 supplemental paid sick leave and provide covered employees up to 80 hours of COVID-19 related paid leave and offer an additional 40 hours available when an employee or family member either needs care for themselves or is caring for someone who's positive for COVID-19. As always, employers are required to report cases, contacts, and clusters of cases during and after an outbreak. Employers are also responsible for making testing available to exposed employees during work hours and at no cost to the employee. And during an outbreak, to afford further protection, employers do need to require indoor and outdoor masking when employees can't maintain social distance and offer respirators to employees at no cost to the employees. So during an outbreak, masks are required for both indoor and outdoor masking if workers cannot maintain social distance. Public health staff will provide employers and employees with additional specific guidance during an outbreak to make sure that we're doing our very best to reduce transmission. To date, most employers have fully cooperated with public health during outbreak investigations, and we're hopeful that they'll continue to implement measures to prevent COVID transmission and protect workers. However, workers who are concerned about possible COVID-19 or other workplace safety issues, or that an employer may not be following the county health officer order or other requirements, can submit a complaint to public health anonymously by calling our call center at 888-700-9995. That's during working hours, Monday through Friday. Next slide. While we're all enjoying having the surge behind us, many frontline workers who have dozens of exposures each day remain at higher risk and appropriately are worried about becoming infected and possibly spreading COVID-19 to others, including their loved ones. We ask that everyone continue to layer in, as appropriate, protections for our workforce members who have, throughout the pandemic, taken on personal risk in order to provide all of us with essential services. And please support businesses that are making extra efforts to protect their employees and their customers. There are also, as you can see here, some sensible steps that each of us can take to help protect our workforce. Wear a well-fitting mask or respirator when you're indoors in close contact with workers. If you're sick, please stay home from work, public sites, and events. We ask still that you get vaccinated or boosted if you're not already. This is the best way to protect essential workers and, frankly, our entire community from COVID spread. Please follow any COVID-19 rules at work sites, stores, and events, since businesses may have their own safety measures in place. And if you have safety concerns, you can report them to the union representatives, if there are union representatives, Cal OSHA, or to public health through our anonymous complaint line, or go on our website. You can submit that 24 hours a day on our website. For those that are comfortable continuing to take sensible safety precautions for a bit longer, we thank you. This will help protect our workforce and others while we try to drive down transmission rates to a level where fewer people will be exposed. Thank you, and I'm now available to take your questions.
Thank you so much, Dr. Ferrer. Our first question comes from Ryan Carter from LA Daily News. Ryan, you're unmuted.
Hey, good afternoon. Thank you very much, Dr. Ferrer. Good afternoon. Maybe just a couple of questions here. One is, I wondered if you could just sort of reiterate or elaborate the substantial spread metric. And I apologize that I'm not on that. I was wondering if you could just reiterate that. And also, is the R naught sort of index still a part of that consideration? Number two, I've heard it said that it's inevitable that the BA2 subvariant will come to LA County, but is there something about LA County that might be in the back of your mind in terms of like why? Is there something unique to us that where it wouldn't be inevitable? And finally, we've got a marathon this weekend. We've got spring break coming up at many places. Any words of wisdom? Just is this a very different year from the last couple of years where, spread has been a real concern in the background for those events? Thank you.
Yeah, thanks so much for those questions, Ryan. And sorry, I should have been clear. Substantial spread still defined by CDC for us. It's when we have between 500 and 50 to 100 new cases per 100,000 people. Remember, we get to moderate spread when we're below 50 new cases per 100,000 people. That's a 7-day count of cases. And we were in high transmission when we were over 100 new cases per 100,000 residents. So it's good for us all to be reminded what it means. I mean, essentially, it means we still have a lot of transmission. And as we had noted much earlier on, our goal is to get us to a place where transmission is as low as possible, but certainly to get us back down to moderate transmission. And just, just to jog everyone's memory, last March through, I think, the middle of July, LA County was enjoying moderate transmission, so with the same definition. So, it's attainable. We were there last spring. Our hope is that we quickly continue with the decline, continue to take some sensible precautions to help drive transmission down a little bit lower, and can enjoy what really is less risk for everyone when transmission is lower. In terms of BA2, we already have BA2 in the county. About 6.5% of what we sampled, and this goes back almost a month at the end of February, were sequenced specimens that had that indicated the BA2 subvariant. And again, there's this lag time because it takes a while to sequence the specimens. CDC was estimating for the country as a whole that about 25% of the specimens appear to now be BA2. So my assumption is it's here. It's likely to increase. I see no reason why it won't, in fact, become a more dominant strain. I don't know how long that will take, and I don't know that it will completely wipe out BA1. We could have both of those strains circulating. I mean, BA2 is advantaged because it's 30%. It's thought to be 30% more infectious than BA1. So it's going to spread more. More people will have BA2 than have BA1. And that will leave us with BA2 being the dominant strain. I think what we're not able to predict with certainty is what's the impact of having more BA2 as opposed to what we have now, BA1, on severe illness, particularly on what happens in our hospitals. I do want to note some countries in Europe are already starting to see those increases in hospitalizations. But again, as I noted, these increases in cases and hospitalizations are happening while there's more BA2, but there's also less public health measures. And as we all know, there's waning protections for some people from the vaccines, particularly people who didn't get boosted, and there's still lots of people who aren't vaccinated. So I'd say it's a complicated picture in front of us. As I noted, I think the most important thing we do as a county is continue to be sensible about our precautions and really continue to try to get transmission as low as possible by being sensible about taking, really what I consider fairly, at this point, fairly easy precautions. But most importantly, that we prepare ourselves by improving our vaccination rate and certainly coverage from boosters. In terms of the last question, we are about to have a wonderful marathon here on Sunday. I hope a lot of people have an opportunity to go out and cheer on our runners. I want to commend, the organizers of the marathon. As always, they're attentive to really what we consider routine infection control processes. We encourage people to try to distance as much as possible. And if they're indoors gathering before the runs with lots of people, to keep those masks on. Obviously, for the spectators, we'll all be outside watching. We can do our best to keep our distance. If you feel like you're in a crowded area and you're a person particularly at higher risk, or you live with people at higher risk, or you're unvaccinated, in those crowded situations, we obviously continue to recommend that you keep a mask on. In terms of spring break, again, testing is a really good strategy to keep in mind, particularly if you're traveling, testing before you go to make sure you're not taking something else with you besides your luggage, and then testing after you return, particularly important for unvaccinated people or people not fully vaccinated, or for people who are at higher risk. I am going to note that all of the schools in our county are in the process of having over-the-counter, those at-home test kits delivered to them in time for them to distribute them to their students before spring break. Again, with the same effort we made when children were returning from winter break, which is for students to be able to test before they come back into the classroom. So I think there are sensible precautions that we've taken before when we've gone into breaks, and that we need to continue to take. I want to especially stress that for people at higher risk, older people, people with underlying health conditions, people who are immunocompromised, children under 5 not yet vaccinated, people not fully vaccinated or completely unvaccinated, these spring break times can in fact increase your individual risk. So, we do ask that you be particularly cautious and use the personal protections at hand to keep yourselves and those you love safe. But thanks for that, Ryan. We can go on to the next question.
Our next question comes from Luke Money from the LA Times. Luke, you're unmuted.
Hey, good afternoon, Dr. Ferrer. Hope you're doing well. Thanks for taking the time to speak with us, as always. 2 questions for you today. The first is, according to an analysis of data from the California Department of Public Health, looking at the date range from December 1st through basically the start of this week, LA County had the highest case rate of any county in California and the 11th highest death rate. Does that surprise you? And what are some of the factors that you think contributed to the county's experience during the Omicron surge? And second, some health officials have expressed concern about a lack of funding at the federal level and how that might jeopardize public access to COVID therapeutics and treatments. Are you concerned at all about that? And looking ahead, do you think there will be sufficient supplies to meet the demand in LA County, particularly among lower income residents? Thank you so much.
Yeah, thanks, Luke. And maybe I'll start with the latter, because I think it's really important. And yes, I'm very worried. We need additional federal funding. It's not just for what happens at your public health department. We have lots and lots of community partners who will not get reimbursed as of March 22nd for vaccinating and testing people who are underinsured or don't have any insurance. And we still have people here who are underinsured and don't have insurance. So it wrecks our network immediately. Because again, it's expensive to do this. We've benefited from having a reimbursement for our community partners, but we can't ask people, our provider community in particular, to do all of this work without adequate reimbursement. So my hope is that swiftly, our federal elected officials are going to work together with the White House, get a package passed, make sure that not only are we continuing to be able to do what we're doing now, but as I noted, we need to be prepared for a potential challenge in the future and in the near future. We don't want to be caught off guard. We need to have supply chains in place. We need people to have PPE. And especially, as you noted, for people who live in under-resourced communities or have less resources themselves, during a pandemic is not the time to go ahead and let everybody be on their own in terms of doing what's needed to be done to, have the most protections you can possibly have during a pandemic. We need to make that access as we have available to everyone, regardless of their ability to pay or where they live. And my hope is that, the federal government appreciates all that has been done in local communities to make sure that we're able to have these vast networks to meet the demands right now on testing and vaccines and the soon-to-be demand to distribute those therapeutics. In terms of the data on LA County and how hard we got hit with Omicron, I mean, we all lived through it. So I don't think it comes as a surprise to us at all. We are a very large county. We have some of the densest neighborhoods in the entire country. We have also many people, an extraordinarily large number of people who live in communities that are both under-resourced and who they themselves are living at or below the poverty level, making it, again, super hard for folks to have the resources that they might need to protect themselves. We're also an industrial county. We have a lot of heavy industry. We have a lot of manufacturing industry. We have ports. We don't have what some other communities have, high numbers of people that were allowed to or had the opportunity to do a lot of their work teleworking. So throughout most of the Omicron period, nothing closed here, but and that had its advantages, kept us on a recovery journey, but also created a lot of exposures for people, who work in all of these essential services that were open during the entire pandemic. I don't think at the beginning of the Omicron surge, we appreciated how very contagious this new variant was. And I think, in fact, in a community our size, with as much industry as we have, we really did take a very hard hit. I also appreciate that people did their very best to protect themselves and others. And certainly on masking, we had masks on before the variant actually took off, which I think helped us as well. But appreciate that.
Our next question comes from Jackie Fortier from KPCC. Jackie, you're unmuted.
Hi there. Thank you for taking our questions. I believe you said 13% of tests are being sequenced, and if memory serves, that's a lower percentage than earlier in the pandemic. I think it was 20 or 25%. So why has the percentage of tests being sequenced decreased? And then I'd like to know, do we know whether infection with BA1 offers any protection from BA2? And I'm just kind of curious. Well, I feel like I should also ask why you are wearing a mask right now. And I think a lot of people are confused since we're seeing a wave of, BA2 starting in the Northeast. It feels a lot like 2 years ago, while at the same time the mask mandates have disappeared. I mean, how worried should people be about the BA2 subvariant? Thank you.
Yeah, thanks so much, Jackie. And I'm wearing a mask. There's somebody else in my office with me today, so we keep our masks on in our offices here. In terms of your question on the sequencing, yes, it is a decrease. Mostly it's attributed to CDC no longer paying for all of the sequencing they paid for during the Omicron surge. So CDC was actually contracting directly with large national labs to do sequencing in places like LA. So with that contract not being in place, we have slightly, as you noted, slightly less sequencing taking place. I do want to note that across the country, somewhere between 10 and 15% of sequenced specimens is really thought to be adequate. We were really pleased to have had it at a higher level. And again, as part of our preparedness, we want to make sure we've got capacity to increase our ability to do sequencing, because there's less testing that is going on now compared to what was going on in the height of Omicron. So we need to make sure that during high moments of high transmission or weeks of high transmission, we retain that capacity to stay up around somewhere between 10 and 15%. So we have work that we're doing right now to ensure that we will have that capacity here. In terms of the question about how much protection do you have if you were already infected with Omicron, most likely BA1, against BA2, so far, there's only a handful of cases of people who were previously infected with BA1 that were subsequently infected with BA2, but it's early in sort of the research cycle on this. I will say that, in all likelihood, there's some protection for many of the people, but nothing's perfect. And again, should we start seeing a lot more BA2 circulating, we all need to, take additional caution, particularly if we're at high risk. I would suggest that people who were infected with Omicron and are not yet vaccinated or boosted take this opportunity before BA2 starts circulating more widely to go ahead, add in that layer of protection by getting your initial series. And for sure, if you haven't yet gotten boosted and you're counting on the fact that you just had Omicron, 2 or 3 months ago, it would be a good time for you to come in now and go ahead and get that booster dose. It will just help you have additional protection from what is a subvariant of concern. So I think I got to all your questions, Jackie. Thanks.
Our next question comes from Marla Tellez from Fox 11. Marla, you're unmuted.
Hello, Dr. Ferrer. Thanks for taking my questions. I just have two, and the first one is, how soon do you expect BA2 become that dominant variant here locally? And number two, I'm one of the crazy 25,000 runners running the LA Marathon on Sunday. And I was personally a little concerned when I saw that there isn't a vaccine requirement. So I'm curious how that strikes you and your advice for the runners out there on Sunday.
Yeah, thanks so much. Let me quickly go to how soon would BA2 become dominant. I have no idea. It, became dominant over a period of a few weeks in Europe. It's certainly, there are higher rates of circulating BA2 in the Northeast and the East right now than there are out West. But I think we can expect that we're going to continue to see increases in BA2 because, again, it has this advantage. It's more infectious than BA1, so it's going to crowd out BA1, and that would allow more and more of it to circulate. Again, the best protection we all have is more people vaccinated, more people boosted, less places for either BA1 or BA2 to thrive. And in terms of advice around for the runners, well, first of all, congratulations, and I hope you have a great run. And my advice is at this point, you need to assess your own risk and then take as many protective measures as appropriate. I do suggest that, you have your mask handy for, when you're in the corrals, when you're waiting to go. It's easy to actually, slip off that mask once you start running. So I would strongly suggest that. There are no vaccination requirements for entry into these sports. We do know, and we're fortunate that the vast majority of people in this country are at this point vaccinated. My hope is that that includes a lot of runners. But since you don't know, it does mean, being extra cautious yourself. I suggest no shared water bottles. I think that's obvious, to keep yourself safe. And that's, really a good idea no matter what. And that, you make use of hand sanitizing stations along the way. But, keeping your distance from other runners, not being super crowded once you take off. I think we'll make sure that, you're both staying safe and you're having an excellent run on Sunday. So, and again, congratulations.
Our next question comes from Lynn Tott from the LA Daily News. Lynn, you're unmuted.
Hi, Dr. Ferrer. As you are most likely aware, LAUSD is negotiating with its teachers union right now to lift the district's indoor masking mandate. And we understand that UTLA has proposed lifting the mandate only at schools where at least 75% of students and staff are fully vaccinated. Your office lifted your masking mandate without setting any sort of threshold on vaccination rates. But I am curious to get your thoughts on whether you think setting such a threshold is actually a good idea, and specifically, is 75% a reasonable request, or is there no need for such a threshold? Thank you.
Yeah, thanks so much. This is a really important question. And first I want to thank LAUSD and, all the people that make up the LAUSD community. These are really hard decisions to make. It's hard to find consensus and agreement. It is absolutely essential that workers feel safe. And in this case, the teachers and staff need to feel safe. They're doing hard jobs that have been made harder by the pandemic. So I appreciate, wherever we have our labor partners negotiating on behalf of keeping workers safe, that we pay a lot of attention to what workers are saying as to what they need to feel safe during a pandemic. We align fully with the state. So, I want to note that one of the things the county did during this post-surge period was try as much as possible to stay aligned with the state for a variety of reasons, but mostly because these are confusing times and having us aligned as much as possible makes sense. We also recognize that in aligning fully with the state, should we see any of our early alert signals start notifying us that we have areas where we need to be concerned, we can make those modifications. And schools is certainly one of the places where we're tracking information on a daily basis to make sure that schools stay as safe as possible. I don't think it's a bad idea to look at vaccination rates in relationship to safety around COVID-19, because we know from, at this point, over a year's worth of data, how much protection people have who are vaccinated and boosted, and how much harder it is for there to be a lot of transmission in places where people are fully vaccinated and boosted. We also know the vaccines aren't perfect. We also know that at 75% of folks being vaccinated in any community, you're unlikely to have reached the level of what we were calling community immunity, but you will still have a lot of protection in those settings. Even now, with Omicron, looking at sort of the Omicron data, we still see that people who are fully vaccinated 2 times less likely to get infected. If they're fully vaxxed and boosted, almost 4 times less likely to be infected. So I don't think there's anything illogical about looking at vaccination rates. And again, I want to stress how important it is for the workers to feel safe at the jobs that we ask them to do. So I appreciate that everyone's at the table. I appreciate that people have lots of different perspectives on what, whether or not it's essential for everyone to wear a mask. But I think, we really need to respect our labor unions and our workers and being able to negotiate what creates safety for them as well. We need them to be safe, and we need them to feel comfortable doing what are very hard jobs. So thanks for that. And I think we're out of time. So I apologize if we didn't get to your question, but feel free to send it in and we will definitely respond to that. But I know I'm out of time, so.
Yes, thank you so much to everyone who joined us today. Any additional press questions can be sent to our media inbox at media@ph.lacounty.gov. If you'd like to stick around, our Spanish remarks will be in just a few minutes. Otherwise, we'll see you next week. Good afternoon, Monica. Are you there? Oh. There we go. Good afternoon, Monica.
I was like, okay,
My apologies.
no problem.
All right. Good afternoon, everyone. Thank you so much for joining us for the Spanish portion of today's briefing. Today is March 17th. We have Monica presenting. Monica, when you are ready.
Thank you so much, Kim. Muy buenas tardes y gracias a todos por venir a la sesión informativa de hoy. Compartiremos la actualización sobre el estado de la pandemia, analizaremos nuestros esfuerzos posteriores a la oleada de casos y daremos a conocer medidas para proteger a nuestros trabajadores. First slide, please. Nuestro condado se encuentra en un lugar mucho mejor que hace unos meses, cuando estábamos en el pico de la oleada invernal. A medida que avanzamos hacia la primavera, el contagio comunitario ha disminuido, lo que ha hecho que bajen las hospitalizaciones y se ha reducido la congestión en nuestro sistema de atención médica. Según la metodología de riesgo de los CDC, el condado de Los Ángeles permanece categorizado en un nivel de riesgo comunitario bajo y afortunadamente en las últimas semanas también hemos visto morir a menos personas por el virus y esto es un gran alivio. Sabemos que nuestro progreso se ve favorecido por las medidas de protección tomadas por muchos de nuestros residentes, sector comercial, empresarial, escuelas, proveedores de atención médica y otros antes, durante y después del previo del aumento del pico de hace algunos meses. Y aunque no serán para siempre, estamos fomentando un enfoque continuo de medidas de seguridad sensatas por un poco más de tiempo hasta que tengamos menos virus circulando y la disminución y la transmisión comunitaria ya no sea sustancial en el condado de Los Ángeles. La disminución de la propagación significa que hay un riesgo reducido para todos nosotros, en particular para aquellos que son más vulnerables a enfermedades graves y quienes tienen un mayor riesgo de exposición debido a su tipo de trabajo. Comenzaremos con las métricas de la semana pasada y como puede ver, los casos y las hospitalizaciones continuaron disminuyendo. Hoy estamos reportando 1.331 nuevos casos. El número promedio de casos nuevos diarios informados durante los últimos 7 días se redujo a un promedio de 950 desde los 1.100 casos nuevos diarios de la semana anterior. Comparando el 10 de marzo con el 17 de marzo, el número de casos notificados a diario disminuyó un 2,2% por día. Si mantenemos esta tasa, pasaríamos a finales de marzo de un contagio sustancial a moderado. Nuestra tasa de casos diarios promedio de 7 días ha disminuido a 9 casos nuevos por cada 100,000 residentes. Nuestra tasa de positividad diaria promedio de 7 días también se ha mantenido por debajo del 1% o en 0,7% durante casi las últimas 2 semanas. En comparación, el 2 de enero, la tasa promedio diaria de positividad de la prueba fue del 23%. Las hospitalizaciones, un componente clave de las medidas a nivel comunitario de los CDC, han seguido disminuyendo y estamos informando que 495 personas están actualmente hospitalizadas en comparación con 632 el jueves pasado. Finalmente, como se señaló, las muertes diarias reportadas se redujeron a un promedio de 34 al día frente a un promedio de 40 muertes al día la semana pasada. El Departamento de Salud Pública envía condolencias a los seres queridos de los cientos de residentes del condado de Los Ángeles que fallecieron por el COVID la semana pasada y a todos los demás que han perdido a un familiar o amigo desde el comienzo de la pandemia. Next slide, please. Los jueves podemos publicar las métricas actualizadas en nuestros indicadores de panel del nivel comunitario de los CDC. El primer indicador es la tasa de casos de los últimos 7 días. Hasta ayer, la tasa de casos del condado de Los Ángeles era de 85 nuevos casos por cada 100,000 habitantes. Como puede ver en esta diapositiva, se mantiene por debajo de los 200 casos nuevos por cada 100,000 personas. Los indicadores restantes en este panel son indicadores hospitalarios que sirven como indicador del nivel de congestión del sistema de salud. El primero es la tasa acumulada de 7 días para nuevas admisiones hospitalarias por COVID. La tasa actual de 4,5 admisiones por cada 100,000 habitantes cumple con los criterios de los CDC para el nivel comunitario bajo. El segundo indicador hospitalario es el promedio de 7 días para la proporción de camas que cuentan con personal y están ocupadas por pacientes con COVID-19, que es 3,2% para el condado de Los Ángeles hoy. Esto también se considera en el nivel comunitario bajo. Con base en estas tres métricas, nuestro nivel general de riesgo comunitario se mantiene bajo esta semana sin necesidad de cambios en nuestras estrategias generales. Next slide, please. Esta diapositiva muestra nuestro progreso desde el 1 de octubre del 2020 en ambos indicadores hospitalarios. El primero son las admisiones diarias que se muestran con la línea amarilla y el segundo es la proporción de camas ocupadas por pacientes con COVID que se muestra en la línea rosada. Como puede ver, estos indicadores se han seguido bastante cerca entre sí y esta semana ambos han continuado su declive desde el pico de la oleada de invierno y ahora están cerca de los niveles que vimos antes de la oleada. Como se mencionó, ambos califican al condado de Los Ángeles en el nivel bajo de riesgo comunitario de los CDC. Next slide, please. El siguiente componente de nuestro plan de respuesta posterior a la oleada es nuestro sistema de señal de alerta temprana. Estamos monitoreando un conjunto de 7 señales de alerta temprana, 3 señales de toda la comunidad y 4 señales específicas del sector. Estos nos alentarán sobre posibles áreas de preocupación, lo que puede llevarnos a realinear nuestras estrategias para frenar la propagación del COVID o contener brotes. Cabe destacar que nuestro plan de respuesta posterior a la oleada es un documento vivo que con el tiempo se revisará para reflejar las condiciones del momento. Esta semana hicimos varios cambios en nuestros indicadores de la señal de alerta temprana. En primer lugar, debido a que la Organización Mundial de la Salud recomendó que la subvariante BA.2 se considere como preocupante, modificamos nuestro indicador de variantes preocupantes para incluir subvariantes preocupantes. Según la revisión de datos adicionales, también aumentamos los umbrales para este indicador a menos de 10% para preocupación baja, del 10% al 20% para preocupación media y a más del 20% para preocupación alta. Finalmente, con base en una revisión de los datos de los brotes escolares en relación con la cantidad de total de sitios escolares en el condado de Los Ángeles, aumentamos los umbrales para el indicador de brotes escolares a 7 o menos brotes en el aula para preocupación baja, 8 a 14 para preocupación moderada y 15 o más para preocupación alta. Como puede ver, todas las señales de alerta temprana se consideraron de baja preocupación esta semana. Por lo tanto, no se activan más investigaciones ni cambios en nuestras estrategias de prevención. Next slide, please. Aunque nuestros últimos resultados de secuenciación no generaron un motivo de preocupación, estamos compartiendo resultados de la secuencia actualizados hasta la semana que finalizó el 26 de febrero. No hay nuevas variantes de preocupación que circulen en el condado de Los Ángeles. Omicron sigue siendo nuestra variante predominante y representa el 100% de todos los casos con muestras secuenciadas recolectadas en la semana que terminó el 26 de febrero. Entre los 4 sublinajes de Omicron que se han identificado, el linaje BA.1.1, linaje descendiente del BA.1, sigue siendo la principal subvariante de Omicron detectada en casos en el condado de Los Ángeles. Aquí estamos también viendo un crecimiento gradual de la subvariante BA.2 junto con una disminución continua de los casos de COVID-19 en general. Para nuestro último periodo de medición, la semana que finalizó el 26 de febrero, el 6,4% de todos los especímenes secuenciados en el condado fueron BA.2. Para esta semana se secuenció el 13% de las muestras positivas. En los Estados Unidos existe una amplia variación geográfica en el porcentaje de variantes secuenciadas que son BA.2. La región del nordeste muestra un porcentaje más alto que el oeste y nuestra observación es que el condado de Los Ángeles se encuentra dentro del rango observado a nivel nacional. Como muchos saben, la variante BA.2 es ahora la que domina en algunos países, incluidos algunos en Europa, que enfrentan aumentos repentinos en los casos y un incremento en las hospitalizaciones. Es un desafío descifrar el papel de BA.2 en el creciente número de casos en Europa. BA.2 llegó a cada país en diferentes momentos, pero la cantidad en aumento de casos está ocurriendo en momentos similares en la mayor parte de Europa, lo que podría sugerir que la circulación de BA.2 en estos otros países no es el único factor que influye en el número creciente de casos. Además, el número de crecimiento de casos se produjo poco después de la suspensión de las medidas de salud pública diseñadas para limitar la transmisión de COVID-19 en muchos de estos países y enfrentar la potencial disminución del efecto de las vacunas. Si bien sabemos que muchos en el condado de Los Ángeles tienen una protección significativa contra BA.2 a través de la vacuna y o una infección reciente con otro virus del linaje Omicron, estamos siguiendo de cerca la información de Europa, ya que los patrones que se ven en Gran Bretaña generalmente se ven en los Estados Unidos unas pocas semanas después. Y aunque no hay certeza de que experimentaremos los aumentos repentinos observados en muchos países europeos, dada la probabilidad de que BA.2 se convierta fácilmente en la cepa dominante, tenemos la oportunidad de prepararnos de manera proactiva, manteniendo protecciones de seguridad sensibles, sensatas y mejorando los niveles de vacunación y la cobertura del refuerzo, en particular entre los más vulnerables. Next slide, please. Continuamos asociándonos con las escuelas para minimizar los riesgos de una mayor transmisión y estamos agradecidos por los esfuerzos que hasta la fecha han resultado en altos niveles de seguridad. A medida que hagamos la transición para eliminar los requisitos de uso de mascarillas, realizaremos un seguimiento cuidadoso de los datos en las escuelas durante las próximas semanas para garantizar que el contagio se mantenga bajo. Como puede ver en esta diapositiva, en el último periodo de informe de 7 días que finalizó el 15 de marzo, solo se abrieron 2 brotes en las aulas escolares. Next slide, please. Junto con estos hallazgos, otros indicadores también señalan que hubo un menor riesgo de propagación del COVID en las escuelas. Esta diapositiva muestra las tasas de resultados positivos de las pruebas periódicas y de respuesta realizadas en los planteles hasta el 11 de marzo. Como se señaló antes, la reducción en el volumen de pruebas se debe a la exclusión apropiada de las pruebas de los estudiantes que recientemente dieron positivo por COVID-19. La tasa de positividad de la prueba continúa disminuyendo y actualmente es inferior al 1%, es decir, 0,22%, que es más baja de lo que era al comienzo del año escolar, durante gran parte del año escolar y menor que el porcentaje de positividad de la prueba comunitaria. Aunque no se muestra en esta diapositiva, también ha habido disminuciones significativas en la cantidad de casos de COVID entre los estudiantes y el personal de las escuelas primaria, secundaria y preparatoria, así como en los deportes juveniles. Durante la semana del 7 al 13 de marzo se informaron alrededor de 475 casos de estudiantes en los 4 entornos. Esto es solo un poco más de casos de estudiantes de los que se informaron solo en las escuelas primarias la semana anterior. Durante el mismo periodo, los casos entre el personal también mermaron significativamente, con solo 52 casos reportados por todas las escuelas, que es menos de la mitad del número informado la semana anterior. De hecho, dado el hecho de que hay operando en el condado más de 3.100 escuelas de transición a grado 12. Estos números de casos son impresionantemente bajos. Apreciamos que con estas tasas de transmisión aminoradas existe la oportunidad de reevaluar las precauciones de seguridad vigentes. Sin embargo, notamos que todos los miembros de una comunidad escolar pueden continuar haciendo su parte para mantener baja la propagación al quedarse en casa cuando están enfermos, seguir la guía de cuarentena y aislamiento y usar mascarillas cuando están en el interior de la escuela. Next slide, please. Aunque compartimos el alivio de que COVID-19 está menguando en el condado de Los Ángeles, tenemos un plan de preparación y las métricas que lo acompañan para guiar los esfuerzos para estar preparados ante la posibilidad de futuros aumentos repentinos y variantes que podrían propagarse más fácilmente, causar enfermedades más graves o evadir la protección que ofrece la vacuna. Hoy también contamos con un nuevo panel de preparación que permitirá a todos marcar nuestra preparación para responder a condiciones y desafíos cambiantes. El tablero consta de 13 indicadores que abordan las 5 áreas claves de nuestro plan de preparación: gestión de brotes, pruebas, vigilancia, vacunas y tratamientos. Los 3 umbrales que evaluamos son si en un área particular necesitamos mejorar o si tenemos una capacidad adecuada o excepcional. Cuando nuestras métricas sugieran la necesidad de mejorar, tomaremos medidas para ajustar nuestras acciones, para enriquecer la preparación y poder rastrear cada semana nuestras mejoras en la capacidad. El tablero se publicará hoy como parte de la página web Plan de Respuesta Posterior a la Oleada. Hoy revisaremos rápidamente cada métrica y en las próximas semanas nos concentraremos solo en las áreas donde se necesita mejorar. Después de revisar el tablero, también presentaremos 2 de las áreas de enfoque de preparación: pruebas y gestión de brotes. Las primeras 4 métricas se relacionan con el acceso a las vacunas. Hemos alcanzado el umbral excepcional para la cantidad de sitios de vacunación móviles por semana y el número de sitios de vacuna fijos. Se necesita mejorar las otras 2 métricas de vacunas. El primero es el porcentaje de autorizaciones a personas confinadas en el hogar que recibieron su vacuna dentro de las 2 semanas posteriores a la fecha de la autorización. Y la segunda área donde se necesita mejorar es el porcentaje de residentes de 12 años o más en las comunidades más vulnerables que han recibido al menos una dosis adicional o de refuerzo. Alcanzamos el umbral de adecuado para nuestra métrica de preparación para la gestión de brotes, que mide el porcentaje de brotes en nuestro lugar de trabajo de alto riesgo que recibieron al menos una visita de nuestro equipo de brotes del Departamento de Salud Pública. Bajo el nivel posterior a la oleada, los brotes de alto riesgo en el lugar de trabajo se definen como 1, entornos de trabajo de fabricación o almacenamiento con al menos 50 empleados; 2, aerolínea o aeropuerto; o 3, cualquier industria con 5 o más casos vinculados epidemiológicamente. Existen 2 medidas de preparación relacionadas con el acceso a los tratamientos que se definen para estos efectos como medicamentos orales e inyectables utilizados para prevenir la infección o el avance de la enfermedad. La primera métrica, que es la cantidad de sitios en las comunidades más vulnerables que dispensan terapias, se calificó como necesita mejorar. La segunda métrica evalúa el porcentaje de residentes que reúnen los requisitos, recibieron el tratamiento y se comunicaron con nuestro centro de llamadas de información sobre COVID-19 de salud pública. El resultado de esta medición está pendiente y se informará cuando esté disponible. Next slide, please. El siguiente conjunto de métricas se relaciona con la preparación en el área de pruebas. Alcanzamos el umbral excepcional para el tiempo de espera promedio para la prueba en todos los sitios de prueba administrados por el condado y para el porcentaje de escuelas de transición a grado 12 que tienen capacidad para dar el test de respuesta. Se considera adecuado nuestro desempeño en la métrica relacionada con el porcentaje de los centros de enfermería especializada que tienen capacidad para hacer pruebas de respuesta de rutina. Sin embargo, es importante tener en cuenta que para las pruebas de respuesta en dichos centros establecemos el umbral de sobresaliente en 100%. Nuestra tasa actual es del 99%. Alcanzamos el umbral adecuado para los 3 indicadores finales que están relacionados con la preparación para la vigilancia. El primero es el porcentaje de muestras de casos positivos que se secuencian por semana, lo que contribuye a nuestra capacidad para identificar variantes de interés y de preocupación. El siguiente es el número de áreas de planificación de servicios representadas en la recolección y análisis de aguas residuales 3 veces por semana, que es una medida de nuestra capacidad para identificar rápidamente un aumento en la presencia del virus SARS-CoV-2 en las aguas residuales. La métrica de vigilancia final mide el porcentaje de departamentos de emergencia que nos informan datos sobre enfermedades similares a COVID-19. Los incluidos remitirán estos datos a través del sistema de vigilancia sindrómica. Next slide, please. La semana pasada nos enfocamos en la preparación y tratamientos. Esta semana queremos tomarnos un minuto para hablar sobre las pruebas y la preparación para el manejo de brotes, comenzando primero por las pruebas. El amplio acceso a sitios gratuitos que ofrecen el test, junto con los juegos de prueba en el hogar o caseros, son clave para nuestra respuesta posterior a la oleada. Esto asegurará que podamos identificar, tratar y aislar casos rápidamente e identificar contactos. Tener los resultados de las pruebas a tiempo también puede permitir que las personas sepan cuándo evitar el contacto cercano con los demás y cuándo buscar tratamiento. Este mapa muestra los 78 sitios de prueba del condado y los sitios de prueba estatales y los lugares administrados por otros proveedores. En estos puntos, las pruebas están disponibles sin cargo para los residentes, independiente del seguro médico o el estado migratorio. Es importante tener en cuenta que muchos proveedores también ofrecen pruebas a sus pacientes y que hay sitios de prueba temporales, ninguno de los cuales está capturado en este mapa. Next slide, please. Si bien los sitios fijos ofrecen acceso a cualquier persona que necesite hacerse el test, parte del plan de preparación exige garantizar la capacidad para hacerse la prueba en entornos de alto riesgo, incluidas las escuelas. Esta diapositiva muestra el porcentaje de escuelas públicas de transición a grado 12 que tienen la capacidad de hacer test de respuesta, lo que ayuda a las escuelas a identificar infecciones asintomáticas y tomar medidas para prevenir una mayor propagación de COVID. Como puede ver, entre mayo y julio del 2021, cuando las escuelas se unieron a la labor de proporcionar pruebas, el porcentaje de escuelas de transición a grado 12 con capacidad para realizar estos tests aumentó significativamente y para agosto más del 93% de distritos escolares tenían esta habilidad, por lo que alcanzaron el umbral excepcional para esta medida de preparación. Mantener esta disponibilidad para hacer pruebas en las escuelas es una parte importante para mantener seguros a las personas en los centros educativos. Next slide, please. Las pruebas siguen siendo una estrategia esencial durante esta pandemia y no queremos volver a experimentar escasez para acceder a ellas. Y hay muchas personas que necesitan tener un buen acceso al test, incluso cuando la transmisión es menor. En todo momento debemos asegurarnos de que aquellos que tienen síntomas o han estado en contacto cercano con alguien con COVID puedan hacerse la prueba lo antes posible para que si están infectados puedan aislarse rápidamente y si es necesario recibir tratamiento médico. Además, debemos facilitar que aquellos que se están aislando o están en cuarentena sepan cuándo pueden terminar y regresar a sus labores normales. Por ejemplo, las personas asintomáticas que están aisladas o en cuarentena pueden finalizar su periodo de aislamiento antes de tiempo si tienen una prueba negativa de una muestra recolectada el día 5 o después del periodo de aislamiento o cuarentena. Hay muchas personas que necesitan hacerse la prueba como parte de un programa de detección o un esfuerzo de manejo de brotes en el trabajo o en la escuela o para ingresar a ciertos eventos o instalaciones. Y si bien los programas de pruebas de detección pueden no ser tan esenciales cuando la transmisión es baja, existen entornos de alto riesgo, incluidos los hogares para ancianos, donde se puede justificar las pruebas de rutina. Las pruebas también se recomiendan o requieren para viajar. Por ejemplo, si no está vacunado por completo, debe hacerse una prueba viral de COVID-19 de 1 a 3 días antes de su viaje nacional y volver a hacerse una prueba viral de COVID-19 de 3 a 5 días después de regresar a California. Y aún sugerimos que las pruebas antes y después de eventos y reuniones sean sensatas, especialmente si usted o alguien con quien se reúne o alguien con quien vive tiene un mayor riesgo de COVID-19 o de enfermarse gravemente. Es importante destacar que nuestros esfuerzos de preparación deben garantizar que podamos aumentar la capacidad de prueba cuando la transmisión es mayor. Next slide, please. Hay muchos recursos disponibles para aquellos que necesitan hacerse la prueba de COVID. Para acceder a todos los detalles, las personas pueden visitar nuestra página web de pruebas, incluidos los criterios para los programas de prueba y enlaces a listas de sitios de prueba. La dirección se encuentra en la parte inferior de la imagen. Esta diapositiva también contiene una lista completa de los recursos de prueba en todo el condado. Para contar con la capacidad de test que se requiere para estar preparado, implica hacer un uso de todas las nuevas tecnologías. Así que, como puede ver, aquí en el condado de Los Ángeles hay varias opciones. Ir a un lugar a que la persona se haga la prueba, recolectar la muestra en la casa y enviarla para el análisis o usar una prueba casera. No deberán costar nada las pruebas que se hacen en un sitio. Las personas con seguro médico pueden hacerse la prueba en cualquier proveedor dentro o fuera de la red de su plan de salud sin costo alguno. Las pruebas también son gratuitas para las personas que no tienen cobertura de salud. Sin embargo, es posible que algunas personas deban pagar los juegos de prueba en el hogar y algunas pruebas de resultados rápidos. Si bien la mayoría de los sitios no deberían cobrar por estos, se recomienda que confirme que el lugar no le cobrará. Si alguien sospecha que un sitio de pruebas de COVID es una estafa o está haciendo un fraude, puede denunciarlo a la página o el link o el enlace que ve también en la parte inferior de en la casilla ubicada en la parte inferior de esta imagen. También tenemos consejos sobre cómo detectar información errónea, estas estafas y los fraudes, y están publicados también en el enlace que encuentra debajo de la casilla aquí en la parte inferior de esta diapositiva. La página web de pruebas de COVID-19, que también está en esta imagen, tiene información sobre tipos de pruebas del COVID, cómo leer el resultado, qué debe hacer, si es positivo y detalles sobre quién debe hacerse la prueba. Next slide, please. Otra actividad esencial de preparación es mantener nuestra capacidad para manejar brotes porque esta es una oportunidad para reducir la transmisión continua. Como puede ver en esta diapositiva que muestra el promedio progresivo de 7 días de brotes activos desde el 1 de julio del 2021 hasta el 15 de marzo de 2022, ha habido miles de brotes en sitios de todo el condado. Los brotes ocurrieron en una amplia variedad de entornos que se dispararon durante nuestro aumento invernal y al igual que otras métricas han disminuido drásticamente en las últimas semanas. Mientras que durante el aumento, los brotes en la categoría de lugares de trabajo y en sitios para profesar la fe fueron los más altos, en la actualidad la mayor cantidad de brotes activos se encuentran entre los centros de enfermería especializada, que se muestran con la línea amarilla, seguidos por los refugios para personas sin hogar, que se muestran en la línea verde. Estar preparado para gestionar los brotes es un aspecto clave de nuestra planificación y de las medidas de preparación que debemos tomar. El porcentaje de brotes de alto riesgo en el lugar de trabajo que han tenido al menos una visita al sitio de funcionarios de salud pública nos permite saber que conservamos la capacidad de respuesta apropiada para cuando haya propagación en los sectores comerciales y empresariales. Next slide, please. Dado que millones de residentes pasan gran parte del día en su trabajo, la protección de la fuerza laboral durante la pandemia y la oleada sigue siendo una alta prioridad. Hacerlo ayuda a minimizar la escasez de personal, reducir las dificultades económicas y evitar la propagación del COVID en las empresas y negocios y de ellos al hogar. Agradecemos a los muchos empleadores que han seguido las pautas de salud pública e implementado medidas para proteger a sus trabajadores, clientes y visitantes, aunque el aumento repentino terminó, la pandemia no. Y como se señaló, todavía tenemos una transmisión sustancial de COVID-19. Por ello, agradecemos el continuo cumplimiento por parte de los empleadores de una serie de medidas que protegen a los trabajadores y limitan la propagación del COVID. Nos referimos brevemente a 4 responsabilidades que los empleadores tienen actualmente. En primer lugar, aunque ya no se requiere el uso de mascarillas en muchos entornos, los empleadores deben proporcionar a los empleados cubrebocas médicos especializados para su protección. En entornos interiores donde se recomienda el uso de tapabocas, pero no se exige, los empleadores deben ofrecer para uso voluntario mascarillas médicas y especializadas que se ajusten bien, como las N95, KN95 o KF94, sin costo alguno para los empleados que trabajan en interiores y tienen contacto con otros colegas, clientes, miembros del público o van en vehículos con más de una persona. Los empleadores que opten por mantener el uso universal de mascarillas en interiores deben proporcionar a los empleados, sin costo alguno, cubrebocas de grado médico que se ajusten bien. Cal OSHA también requiere que los empleadores proporcionen mascarillas especializadas previo pedido para uso voluntario a los empleados que no están vacunados por completo y que trabajan en interiores o en vehículos con más de una persona. Los empleadores también pueden ayudar a promover las vacunas y refuerzos entre los empleados y facilitar que los trabajadores se vacunen o reciben el refuerzo al ofrecerlos en el lugar de trabajo. Los esfuerzos continuos para aumentar la ventilación, reducir el hacinamiento en el interior, alentar el distanciamiento físico, apoyar la higiene de las manos y seguir las pautas de limpieza y desinfección son pasos que crean un entorno de trabajo más seguro para los empleados, para los clientes y los visitantes. Next slide, please. Y si bien muchas de las medidas de prevención son recomendaciones, los empleadores deben asumir un papel activo en el manejo de los brotes de COVID-19 en los lugares de trabajo. Cuando hay un brote allí, los empleadores deben realizar las notificaciones correspondientes, incluida la publicación de un aviso público en el sitio para informar a los visitantes sobre las posibles exposiciones. También están obligados a identificar y notificar a todos los contactos cercanos de la exposición en el lugar de trabajo, así como excluir casos y contactos de su sitio de trabajo hasta que hayan salido del aislamiento y la cuarentena respectivamente. Todos los empleadores públicos o privados con 26 o más empleados también deben cumplir con los requisitos de la licencia suplementaria remunerada por enfermedad COVID-19 de 2022 y proporcionar a los empleados que están cubiertos hasta 80 horas de licencia remunerada relacionada con COVID y ofrecer hasta 40 de esas horas que estarán disponibles solo cuando un empleado o un miembro de la familia a quien el empleado brinda cuidado da positivo por COVID. Como siempre, los empleadores deben informar los casos, contactos y brotes durante y después del brote. Los empleadores también son responsables de poner las pruebas a disposición de los empleados expuestos durante las horas de trabajo y sin costo alguno para el trabajador. Para brindar más protección durante un brote, los empleadores también deben exigir el uso de mascarilla en interiores y exteriores cuando los empleados no pueden mantener distancia social y ofrecer cubrebocas especializados a los empleados sin costo alguno para ellos. El personal de salud pública proporcionará a los empleadores y empleados orientación específica adicional durante un brote para reducir la transmisión. Hasta la fecha, la mayoría de los empleadores han cooperado plenamente con salud pública durante las investigaciones de brotes y esperamos que continúen implementando medidas para prevenir la transmisión de COVID y proteger a los trabajadores. Sin embargo, los empleados que estén preocupados por el posible contagio de COVID-19 o otros problemas de seguridad en el lugar de trabajo o porque un empleador no esté siguiendo la orden del oficial de salud, del condado u otros requisitos, puede presentar una queja ante salud pública de forma anónima, llamando a nuestra central telefónica para clientes de salud ambiental, cuyo número está en la parte inferior de esta imagen y que es el 888-700-9995. Next slide, please. Si bien todos disfrutamos de haber dejado atrás el aumento repentino, muchos trabajadores de primera línea que tienen docenas de exposiciones cada día siguen teniendo un mayor riesgo y están preocupados por infectarse y posiblemente propagar el COVID a otros, incluidos sus seres queridos. Pedimos que todos continúen aplicando, según corresponda, protecciones para los miembros de nuestra fuerza laboral que durante la pandemia han asumido riesgos personales para brindarnos a todos los servicios esenciales y apoya a las empresas que están haciendo esfuerzos adicionales para proteger a sus empleados y clientes. También hay algunos pasos sensatos que cada uno de nosotros puede tomar para ayudar a proteger a nuestra fuerza laboral. Use cubrebocas de grado médico o especializado que le quede bien cuando esté en el interior en contacto cercano con los trabajadores. Si está enfermo, quédese en casa y no vaya al trabajo, a los sitios públicos ni a los eventos. Vacúnese y reciba el refuerzo si aún no lo ha hecho. Esta es la mejor manera de proteger a los trabajadores esenciales y nuestra comunidad de la propagación de COVID-19. Si las reglas de COVID-19 en los lugares de trabajo, las tiendas y los eventos, ya que las empresas pueden tener sus propias medidas de seguridad. Si tiene algún problema de seguridad, puede informarlo al representante del sindicato, a Cal OSHA o a la línea telefónica de quejas anónimas de salud pública que mencionamos anteriormente. Para aquellos que se sientan cómodos tomando precauciones de seguridad sensatas por un poco más de tiempo, les agradecemos. Esto debería ayudarnos a proteger a nuestra fuerza laboral y a otros, mientras tratamos de reducir las tasas de transmisión a un nivel en el que menos personas estarán expuestas. Muchas gracias y nos veremos en la próxima ocasión.
Thank you so much, Monica, and thank you to everyone who joined us today. If you have any additional press questions, you can direct those to our media inbox at media at ph.lacounty.gov. Once again, thank you for joining us, and we will see you next week.